start. Okay, so Bismillahirrahmanirrahim. This is our second lecture over our rheumatology. We have done almost half in our first lecture. So we will try to finish our second half of our rheumatology today, inshallah, inshallah. So we finished, I think, with our, after this chronic fatigue, we told this one, right? Chronic fatigue fibromyalgia, we finished. So just a little review, because these things are interrelated, okay? These things are so interrelated that all the options you will get in the same question. So you need to know how to simply diagnose it and how to simply exclude it, okay? So just a simple point you need to remember with each one. First of all, I want you guys to know actually the way of my own study is to simplify things. I don't like complicated things. Even complicated things, I will simplify by my own method, okay? So the way I am studying by for myself, I am always delivering to others, okay? So I will just simplify this DDs, all the DDs here. And there is echoing. If anything, you can also tell, would you please mute your mic? I think somebody's mic is on mute. If you want to tell something, you can tell or you can just write it up, but please mute your mic. Thank you. Thank you so much. Okay. So first of all, so chronic fatigue syndrome, my key point is tiredness, fatigueness, only fatigue. There will be no tenderness, right? So this is chronic fatigue syndrome. Fibromyalgia, there will be tiredness, but there will be pain, tender point, pain with tender point. So that one was only tiredness. But here the patient will tell you pain, and even he will feel the pain, there will be some tender points. And as I told you, that has to be 11 points at least, specifically from the 18 specific anatomical sites, 11 points has to be positive. I mean, she will, if you are touching her and if you feel more than 11 points are positive, then this is fibromyalgia. Got my point? So first one is only tiredness, chronic fatigue syndrome. Second, I told you fibromyalgia, this is the only pain. Now come if it is with PMR. If it is with PMR, then this is the pain plus stiffness. Pain plus stiffness. So you say I'm just adding one by one word. Got my point? So PMR, this one is with your pain plus stiffness. Just let me write, so maybe it will be clear. So PMR is our pain plus stiffness. Now come another thing we will see later on, where you will we will read it in our neurology, okay? This is polymyositis. There you will get, this stiffness is, this is actually, it should be pain plus, I'm sorry. Okay, so polymyositis, it should be also pain, stiffness, but there should be also weakness of the muscle, which you will not get in PMR. PMR means what? Polymyalgia rheumatica. So that is how these four are differentiated. Is it clear? This is the fourth thing you will get one in the same question maybe. So you need to be very clear. Okay, dear? Okay, so polymyositis, this one actually we will read in our neurology, but as I told you, the questions are not depending on only one chapter. They are giving it a mixed up, okay? They will give you a khichdi, okay? So it's all mixed up. So you need to know how to interrelated the things. So now let's come with our PMR. I told you, I think that day, but just let's recapitulate this one. So PMR, I told you, this is the pain and stiffness. And usually PMR can be overlapping with the GCA. That one is the giant cell arteritis, okay? Giant cell arteritis. So giant cell arteritis, what is this? This is the temporal arteritis specifically. Temporal arteritis. So this one can be associated with your GCA. So, okay, so pain and stiffness, where you will find you will find in the proximal muscle. So how you will know that the scenario, how they are giving in MRCP the question, proximal muscle weakness means what? Your upper limb proximal muscle is your shoulder, right? Your lower limb proximal muscle is your pelvis, right? So they maybe gave you that the patient cannot go up with the stairs up. If with staring up, if he's going up, he's feeling started pain with the in his thigh muscles, or maybe he cannot get up from the chair. One, when you and me, when we are getting up from the chair, we can easily get up, right? But they need to balance themselves because there is I think somebody's mic is, would you please mute your mic? Just a minute. Yeah, thank you. Okay, so proximal muscle weakness means, I mean, they will tell you that they cannot just get up from their chair. That means this is the lower limb proximal muscle weakness, okay? The thigh muscles weakness. And shoulder, they will tell maybe he cannot comb his own hair, or he cannot put his hand up for a long time. So that's how you will get the idea. They are pointing you to your proximal muscle weakness or stiffness, okay? So this is the proximal muscle problem. So this is how the scenario will come. So the stiffness, they will tell you regarding here, pain plus stiffness, as I told you. So they will tell that there is a pain and stiffness whenever she is combing her hair. Okay, that's how the scenario will come. And also the patient is very old, more than 60 years, more than 60 years, like that. Okay, so in this way, the scenario can come in case of your PMR. Okay, dear, let's just clear my drawings. And so you see here in Maghrabi sir's book. So this is, I told you, this is overlapping with GCA because both of them are usually with old people. Okay, and you will get ESR high, especially GCA, you will get more high, but of course PMR also you can get high. Okay, so just let me scroll to the next page. The problem is that if I'm not clearing my drawings, I cannot scroll down or go to the another page. Okay, so as I told you, you see, there should be pain, morning stiffness, and proximal muscles. I told you all the things, shoulder and pelvic girdle muscle. So how the scenario will come, I have already told you. They will not tell you, dear, directly that the muscle, that the patient is having stiffness in her shoulder girdle, a shoulder muscle. No, they will give you a scenario, and you need to know how the scenario can come. Okay, dear? Okay, so as I told you, muscle weakness, this is not a feature. See, that's how he differentiated here with polymyositis. With polymyositis, you got my point? Okay, and also muscle tenderness is not a specific feature. Specific feature tenderness, I told you, 11 tender point, where it is? It is in fibromyalgia. Okay. Now come investigation. Investigation, the main thing your eyes should be there where your ESR. CBC, it could be normochromic normocytic anemia, but you have to see the ESR and specifically CK and EMG, because CPK would be high in case of polymyositis. That's how you can again differentiate from this PMR from the polymyositis. Got my point? So see, even the DD they have given here from polymyositis, that there should be weakness, and also creatine kinase. This is the CPK, okay, CK. Creatine is raised. This is the main difference. So in polymyositis, you will get weakness, and CK you will get high. Which one you will not get in PMR? So that's how you differentiate between these two. Okay, PAN, this is totally different. That was one of the, whenever you see a box in a Maghrabi sir's book, this is actually an explanation. He just copy and paste an explanation, some shortcuts in that box. So don't be confused when you are reading the box. These are the explanation of the other options. Okay, so in that specific question, PAN was also an option, but PAN, you will not that much confused with polymyositis. You need to be confirmed between this PMR and polymyositis. Okay, we finish our PMR. Now the overlapping things, PMR with this GCA, with GCA. Now GCA and PMR almost, they're telling overlapping. So it should be, I mean, Same thing that they are having 60 years old, and onset also rapid, less than 1 month. Same PMR also onset very, very quickly, less than 1 month it will happen. But GCA means what? This is like giant cell arteritis. This is with arteritis, dear. So you cannot get confused with PMR. Yes, they can be overlapping, but obviously these sign symptoms are totally different. How the scenario will come? The patient will tell that I'm having a vision problem. I cannot see suddenly, or there's like blurring of vision, and I'm having severe headache for the last 2 weeks or 3 weeks. Okay. But it was like less than 1 month. Okay. And also I have problem chewing the solid things. Chewing the solid things means what? There is like claudication there's like jaw claudication. You got my point? So jaw or tongue claudication, when the people is experiencing the way they are describing, or the way the MRCP scenario will come, they will tell that I have problem with chewing the solid things. So this is the jaw claudication. Good, got my point? So there will be headache, there can be headache. And please make sure they will not give you all sign symptoms. They are not that much good, okay? They want you to make the things wrong. So they will not give you all the clues. They will give you maybe two clues, or maybe maximum 3 clues. So from that clues, you need to find out the diagnosis. So our clues for GCA is there should be headache, there can be visual problem, there can be jaw or tongue claudication, and yes, sometimes even they will tell that the temporal artery, even the patient is telling there is a like artery, it is like I can palpate in this area, I'm having pain. So this is the GCA. This is the GCA. Okay, so one important thing you need to remember, this GCA can cause the visual loss, AION. Okay, so this is why this is the ischemic visual loss, because of ischemia of that. Ischemic means what? That there is like blood is not going there that much. So that's why they're happening ischemia. After that ischemic is happening necrosis, and ultimately patient lost the visual, the power. They cannot see, they become blind. So if this is happening in less than 1 month, and some patient is coming to you, they're telling, okay, I have some visual problem, blurring, that means it is emergency, dear. If you are suspecting this emergency, and you see in your investigation, not only the sign symptom, obviously they will give you some clue with your investigation. Okay, this is one good point of MRCP. They will always give you clue, at least in the investigation, at least for MRCP part 1. Part 2 is complicated. But part 1, at least they will give you a clue in investigation that yes, sir, is so high. Yes, sir, so high. So now, if they are asking you what you should do now, our investigation for GCA, it should be temporal artery biopsy. Okay, but if just let me draw, if this is artery, maybe the lesion, maybe you take biopsy from here, but the lesion was not here, the lesion was here. So you missed the lesion, you missed it, the lesion was here, okay, you missed it. So this one is a skip lesion. So it can happen that biopsy can give you wrong data, that yes, maybe it is normal. They will give you wrong answer. They can give. This is known as skip lesion. So that is the reason, if they are asking all the scenario with GCA, what is your next management? What you will do? Will you go for the investigation? Will you choose the temporal biopsy, or will you start the treatment immediately? Your answer should be start treatment immediately. Your answer should be start treatment immediately, even with biopsy, because biopsy, even if you are taking, it will take, dear, sometimes to get the result, some days maybe. So you cannot wait for those days to get in the meantime, the patient may get blind. Okay, so this is the important thing they want from. Please mute yourself, because when I'm writing, Dr. Amir Khan, would you please mute your mic? Just a minute, I have to mute, I think. There's some background noise. Okay. So So if they're asking which one you should go, if your option is there, take temporal biopsy or just treat immediately with high dose prednisolone, your option should be high dose prednisolone. Your option should be high dose prednisolone. This is the twist of GCA. Number one. Number two, if they can tell you the temporal biopsy they have taken, all the things I'm telling you, dear, all specifically each and everything when I'm telling question, these are from your question, either from past med or past test or on exam. All of the things I'm telling, it is just exactly towards the MRCP. Dear, I'm not here to give you deeper knowledge about general medicine. It's not possible to teach someone within 4 months deeper knowledge of general medicine. It's not totally possible. What I am doing here, I will correlate and I will try to guide you that which type of questions you will face in the exam. My target is to pass the exam. My target is not to give you deeper knowledge. Okay, so just we need to think smartly. We need to know where the twist and what are the tricks you need to know. Okay, dear. So this is number one. I told you that if there is if they're telling that what you should GCA type presentation, what is your next management? What is your next plan? Our next plan is, it is an emergency, so we will start high dose prednisolone. We will start high dose prednisolone. Okay. Now, skip lesion, it can come. One already temporal biopsy you take and there is a skip lesion you got. What you should do next? Will you repeat the biopsy? Or will you take the, maybe right side he told pain and they took right side temporal artery biopsy. So will you take biopsy from the left side now? Because there is a skip lesion came, but you are highly suspecting this patient is having GCA. So what you should do? I mean, will you repeat it? No. Will you take temporal biopsy from the another temporal artery, maybe on the left side? No. So yes, high dose and low dose, I'm telling you, dear. Low dose prednisolone, this is 10 to 15 milligram up to 10 to 15 milligram, this is the cutoff, okay? And high dose is 40 milligram up, according to the weight of the patient. Usually we are saying 1 milligram per kg per day, this is the high dose, okay? So usually it is 40 milligram up, this is your high dose. Low is 10 to 15 milligram, okay? Got my point? Okay, so this temporal artery biopsy where I was, thank you, Dr. Nitin, for the question. And now temporal artery biopsy, so what should you do? There's the option. We will not repeat the biopsy. We will not give the patient another pain. Already he's in pain there. So we will do ultrasound. We can do ultrasound. Okay. So this is all about your investigation. Now come with the treatment as Dr. Nitin was asking. So our treatment, as I told you, PMR and GCA can be overlapping. But PMR, you will treat with low dose prednisolone. It has to be 10 to 15 mg of prednisolone. It is enough. But in GCA, you need high dose. That has to be 40 to 60 milligram. So it's like counting like 1 milligram per kg per day. Another very interesting clue I will give you. MRCP Part 1, Part 2, never ever they're asking about the dose directly. So you don't need to memorize any dose directly. So it's a lot of burden. Just fall down from your head. Okay, so don't ever just memorize any doses of the drugs. It is not coming. It is not coming in Part 1. Okay, but yes, like this high dose, the word high dose prednisolone, low dose prednisolone, yes, this one are coming, but not like amoxicillin 500 milligram TID for 7 days. No, you don't need to memorize those. So just don't waste your time over those things. Okay, this is the thing. And whatever the medication dose you need to remember, I will tell you with each chapter. Like this chapter, yes, you need to remember which one is high dose and which one is low dose and what is that amount, because yes, this dose is coming. So some specific, maybe maximum 10, maybe maximum 10 diseases you will counter, you will come with the question with the doses, but still they are not that much difficult. Inshallah, one by one, whenever that specific topic will come, I will tell you. So this one you need to remember. So high dose prednisolone, that means 40 to 60. So there is a twist. So just let me tell you, if GCA, if GCA, there is like uncomplicated case. So the question scenario is telling you there is no jaw claudication, there is no visual loss, only the patient came with headache, and already it is determined his giant cell arteritis, but no complication, no visual loss, no claudication, you can go for 40 mg. If complicated, that means already the patient is having visual loss, there is claudication more, okay? So you should dose it up, because complication, right? So you will dose it up. Think very simply. Okay. The important thing is that if the patient comes to you and he's telling that just I am seeing blurring, I'm not blind, I can see your face, but it is blurred, doctor. Okay, that means he's not blurred. Visual acuity, if you check, he has a chance. You have a chance to save his eye. In that case, dear, still not blind, you start with methylprednisolone IV. Methylprednisolone IV. This one you will go for 3 days. This GCA, these doses you need to remember. These GCA doses you need to remember. This IV methylprednisolone you have to go for 3 days. After that, yes, already it is complicated, so maybe you will shift to the oral after 3 days to 60. Got my point? This is the summary of treatment. That's it. That's it. Okay, dear? And whenever there is like prednisolone or NSAID, COX-2 inhibitor, I mean painkiller or prednisolone is there. If they're asking in your question what other drug you should use, what we are giving supporting PPI, right? So always keep it in your mind. Whenever there is a question like painkiller is there, NSAID, COX-2 inhibitor, or maybe prednisolone, if they are already patient is on for some reason, then if they're asking you what is the other drug you should prescribe, that means they want from you that the other supporting drug is PPI to protect the gastritis, right? If you prescribe something, this GCA patient, if you are prescribing prednisolone, if he comes to you after 2 days orally, after that, if he comes to you, I'm having gastritis, so that would not be good, right? So why, doctor, you have given me something that is causing me another problem. So this is the thing, okay? So this is also question. This is also one of your question. Okay, so we have finished our GCA, okay? This is all about our GCA. Another thing, whenever you are starting this steroid, within how many years or months you should stop? You should stop it by tapering. By tapering within 2 hours, 2 years. Okay, so you need to taper, right? This is prednisolone high dose, so obviously you need to taper it, right? Okay, so this one. So there was a question they told that scenario was GCA, but it was with eosinophilia, high immunoglobulin E, sinusitis. So that is different. GCA can be associated with so many things, right? So the scenario will direct you that which answer they want. So this patient, Charles Strauss, inshallah, in respiratory, we will read that just it's a kind of vasculitis. Just put it in your mind, a simple thing. Just it is a kind of vasculitis. So if there is like vasculitis type of feature with positive ANCA means this vasculitis associated. Okay, so you will find, yeah, okay, you will think of any of the choice. Maybe they want us to choose the vasculitis choices. So this is totally different thing. Just here they mentioned because of any question maybe. Okay, that's it for PMR and GCA. Okay, now let's turn to the next one. Takayasu disease. Takayasu disease, this is also a kind of vasculitis. This is what? This is large vessel vasculitis, large or medium vessels. So specifically, some things you need to know that this is happening with the young woman. So I know very many people in my group, I don't know today if they're present because they're from Bangladesh. So, you know, when I first did this topic, this Taka is the currency of Bangladesh. Okay, so whenever you are with me, you will learn something about my country, some words from my nationality. Okay, so I was remembering this, that 30 years of woman was running after the Taka, that means the money. Okay, that's how I was remembering. I'm telling you because these funny things you will remember there, even if you forget everything. Okay, so that is the charm I want you to catch. Okay, that some things that you cannot forget. Okay, so like this. So anyway, so 30 years of women. So usually young women, they are having this Takayasu's disease. And the problem is specifically in the large vessels, but also even, yeah, they can attack also middle vessels also, but that is different. Just if you can remember that young patient with the great vessels, the large vessels involvement, vasculitis, this is Takayasu. What are the organ they can involve? They can involve CNS, CVS, and cardiac. Okay, CNS, CVS, and cardiac. So CNS, they can have maybe some TIA or claudication problem. Cardiac, they can have angina, aortic regurgitation like problem. Renal, they could have like MPGN type of feature. Now, like this, you will not get the scenario, right? How the scenario are coming and how you will diagnose it. Okay, the scenario is coming like that a young patient comes to you and she will tell that whenever she's walking, sometimes after that she's feeling pain in her legs. She started to have pain in her legs. Okay, so you check her legs and you didn't see any kind of vein engorgement is there. After she's taking rest, this pain is relieved. This is claudication. This is they're pointing towards claudication pain. So they will give you one clue like that. They can give you clue like that, or they will give you also clue that there is like bruit. They have bruit maybe on the subclavian or abdominal aorta. Okay, so you can get bruit, or maybe they will give you something about a pulse or BP. So pulse, what they will tell you? They will tell you maybe that there is they checked brachial artery both sided and they found that there is decreased pulsation in maybe one or both of the brachial artery. So pulsation may be getting low, or maybe there is systolic BP difference between the two arms, more than 10 millimeter. So what did I tell you? Just let me write it down so it will be clear a little bit. So it could be they will maybe give you like claudication type of feature. They will give you like pulsation, it is coming low. Okay. They will give you maybe systolic BP. There is a difference more than 10 millimeter in both hand. In right hand, what they are getting, in left hand, it is more than 10. There is a gap. It is not the same BP in both hands. Okay. Or maybe some kind of bruit, they will tell you. Or if they are this much good, if they want you really directly asking, maybe they will give you that, yeah, there is a occlusion. There is occlusion in the aorta, the big aorta, or maybe the primary branches, large artery. So they will give you the arteriographing imaging result. They can give you the arteriograph result. That's how you can easily identify this Takayasu disease. Okay, so this is our large vessel vasculitis, one of the large vessel vasculitis, Takayasu. And how you will treat it? Any vasculitis, corticosteroid. Just learn this today. Any vasculitis, even if you don't know anything, any vasculitis, large, medium, small. If the option, obviously there is some twists and tricks we will learn, but this is your first learning point, that any vasculitis, go with corticosteroid. Okay, so see here, corticosteroid and plus minus steroid sparing drug. If steroid you cannot use, sometimes azathioprine and methotrexate you can use also. So we have finished Takayasu. Dr. Sa, is it clear what I'm saying now? The topics I have told, are those clear? I want answer. If written or verbal, it's okay.
Yes, I guess both is okay. When you are writing is helping also.
Okay, okay. Thank you, dear. Thank you, Dr. Mama. Thank you, Dr. Ibati. Okay. So now we were coming to our cryoglobinemia. Okay. So cryoglobinemia, this is also small cell vasculitis. It's under a small cell vasculitis. Okay. So whatever vasculitis, so this is the small cell vasculitis. Itis means what, dear? Always go with the word. Just dissect it like forensic medicine. Dissect the word, you will get it. So itis means inflammation. Vasculitis, this is like what? Vessels, inflammation. So cryoglobinemia is under small vessel vasculitis. How it happened? When the immunoglobulins are precipitated in a lower temperature at 4 degrees Celsius, then they can damage these small vessels and causing this vasculitis. Very simple. That's it. That's it. Now you need to know it can be associated with so many diseases. It is not single one disease. This can be associated with diseases. Okay. So there are 3 types of cryoglobinemia, and this is so important from rheumatology. And this because this is confusing things, rare things. These all are so favorite of our examinees or examiners, not examinees. You all guys are examinees. So you need to know that there are 3 types. One is type 1, type 2, type 3. So how you will remember? How you will remember? The way I'm remembering, just let me draw it. Maybe it will help. Okay. So this is type 1. This is type 2. Sorry, this is type 2. This is type 3. Okay. So this is monoclonal. This is polyclonal. This is mixed. This is poly and mono, both mixed. Okay, so easy. First thing you already learned. Now come to the next one. What are the association? Okay, type 1 usually associated with Raynaud's phenomenon. With Raynaud's phenomenon, they will give you maybe Raynaud's phenomenon to diagnose the type 1. Type 2 and 3, usually they are having a triad. The triad is what? This is known as Meltzer's triad. So the triad is like, there would be like myalgia, I mean muscle involvement, M, bones, there will be arteritis type of feature, and there will be skin involvement. Just a minute, I want to scroll it down. This one. So skin involvement, that one will show you as a palpable purpura. That could be, okay? Skin with muscle and bones. How I am remembering this? If you think of your body anatomy, after skin, there is muscle. After that, there is bone. That's it. This is Melch's triad. So skin, you will get purpura. Muscle, you will get myalgia. Bones, you will get arthralgia. This one is associated with type 2 and 3. It could be, okay? So that's it. Type 1 can be associated with Raynaud's. Type 2 can be associated with a Melcher triad. So if your question, you got this thing, you will think of cryoglobinemia. If they are also telling that the C3, C4 level is coming down, especially C4. Especially C4 is coming down in case of cryoglobinemia. So this is a very strong clue. This is a very strong clue. So now you will have you will also have to remember the examples of the associations, the type 1 associated with which diseases, type 2 associated with which diseases, and type 3 also association with what. How you will remember this easily? This one, if you remember, like MM, like hematology, MM and WM, like this, just make a table, just make a table by yourself. Just the way I have made it just before that, that type 1, 2, 3. So if you just put here mono in type 1, here mixed, and here polyclonal, then just write down the examples over here. You will find it easier because visual image having more permanent image than, I mean, more permanent memory than only reading. Okay, so better if you can make one table by yourself. So I'm just trying to simplify it to you. So the first one is MM and WM. MM and WM means I'm telling multiple myeloma and Waldenstrom macroglobinemia. Type 3, RA and Sjogren. Type 2, I told you this is mixed. So they also want from type 3 something. So RA Sjogren is there. RA Sjogren already it is there with them. So this is the RA Sjogren, RA Sjogren. Extra, you have to remember Hep C and lymphoma. This Hep C is very, very important. You cannot forget that. Okay, dear. So this is about our cryoglobinemia. So in cryoglobinemia also, RF factor is positive. This high any vasculitis. Another point, I told you, for vasculitis investigation, remember, it is a itis, dear. It is an inflammation. Any inflammation will increase your ESR high, CRP high. So this is the itis of the vessels. So this has to be with high ESR. Okay, dear. So like same GCA, Jansel arteritis, it is with high ESR. Okay, same like if you are saying of this, what's that? I want to tell you, but like that one, Good-Pasteur syndrome. If you are thinking, that is, you will not get high ESR because that is antibody associated. That is the immunological reaction. Okay, so when I will go there, that time I will tell you the differentiation. So the specific thing is that investigation, any vasculitis, you will, most of them you will get high ESR, most of them. If it is not immunological reaction, you will get high ESR. Number two, if treatment, if you are really confused, you forget in the exam hall a specific treatment. If it is vasculitis, go for corticosteroid. So this is my 2 tips. Okay. So now I told you, so cryoglobinemia, they will give you like that, maybe the Meltzer triad along with maybe low C4, RF is positive. So, and also they sometimes they're even telling cryoglobin is high. They have measured, they can measure more than 1. If it is in the blood, the cryoglobin is high, more than 1. Okay. So serum cryoglobulin is high. So it is obviously your cryoglobinemia associated with other disease like type 1, type 2, that association I just told you how to remember. Okay. What is the treatment? You cannot treat this one. This is like a symptoms, right? So you cannot treat it. You have to treat the underlying causes, the underlying diseases. So if you treat the underlying disease, it will be treated. So now come our next topic, Raynaud's. Raynaud's phenomenon. So Raynaud's phenomenon, it is, what is that? This is the changing of the color of the skin, you can see from outside. So this is for because of the vessels, right? So there will be first, there will be whitening. After that, it will be like bluish, then it will be red. So white, blue, and red, like this color triad, it is known as the Raynaud's. So why it is happening? It is happening whitening because there is the vasospasm. Vasospasm means blood cannot go there. If blood supply is not at that area, if sometimes, you know, in our childhood, we are using rubber band around our finger and it's getting white and we were getting so excited because we are doing like not passing the blood over there. So if there is like that vasospasm, if vessel is spasmodic and there is not no flow of the blood, it will be white, right? Because there is no blood inside. And ultimately it will go blue. And then because of pain and at last it can turn to red. Okay, so this is the Raynaud's phenomenon. The important thing what you should know from this Raynaud's is it can be primary or secondary. That means it can be simply they can have, it can showed as himself, not himself, itself as a disease, or it can be associated because of another disease. So if it is caused by another disease, that is, we are telling what? Secondary, right? Secondary to some other disease. That's why they're known as secondary, right? So how we will differentiate? In primary cases, usually this is bilateral. This is very important for you guys. So if it is bilateral and young patient and no complication, no signs, symptoms of other underlying disease, this is primary. So bilateral, our clue is bilateral and young and everything is normal. If they're giving you nail capillaroscopy, nail capillaroscopy will come normal. Maybe they will tell you that there is no rash, nothing is there, no ulceration, no other underlying things, everything fine, only she's having this triad of color when she's exposed maybe to the cold, then this is the primary one. If they want you from secondary, they will give you some clue. Maybe patient is more than 40 years, patient is older, and the symptoms are not bilateral, symptoms are mostly unilateral. there can be some other diseases manifestation. Okay, if it is sclerosis associated with systemic sclerosis, they will give you systemic sclerosis type of feature. Okay, if it is associated with RA or SLE or maybe our APS, they will give you their associated feature of those diseases. You got my point? So if there is like this, if any other diseases sign symptom, that means you will think this Raynaud's is actually caused by another disease. It is not itself. She is not alone. Okay. So, and you have question from here that what is the, I mean, which is the factor that you will differentiate primary from secondary. So this one you need to understand. Okay. So how you will diagnose this one, as I told you, it is known as the capillaroscopy. What is capillaroscopy? Actually, this is the nail fold. They are doing, there is one type of machine is there. They're seeing the nail fold capillary, the blood vessels. In case of primary, the vessels the capillaries are okay. This is not distorted. This is not broken. Supply is good. Okay, only because of exposure to maybe that cold, the patient is having that Raynaud's. So that is primary. Got my point? So see here, normal nail fold capillary, that means it is under primary. But if it is secondary, obviously capillaroscopy, if you are doing, you will find some distortion maybe, or maybe some areas more vessels prominent, some areas vessels are not that much prominent. There is breaking in between the vessels. Got my point? Those are you will find in secondary. Okay. So this is the thing. Here are some secondary causes that which diseases can cause Raynaud's. Okay. Specifically from here, the drugs you cannot ignore. The drugs you need to know, because you will have direct question. What are the drugs that cause Raynaud's phenomenon? Got my point? So you cannot ignore this one. Now here's some DD they mention. DD means, I mean, differential diagnosis. So this chilblain, this is itchy. So it is actually just a red itchy swelling. So in Raynaud's, I didn't mention about itchy, any itchiness, no scratching, nothing will be there. So if it is itchy, red, this is chilblain. Acrocyanosis means cyanosis of the acral part of the body. What is acral part? The limbs. The limbs are called the acral part, upper limbs, lower limbs. So the acral part, you get cyanosed, that is acrocyanosis. So it is only one color, blue. Cyanosis is blue. It is not about our triad of the three colors, right? So this is totally different thing. Erythromelalgia, erythro means what? Redness, right? So this is also, there will be like erythema. So that's some DD they have mentioned. So this is not important, just some DD they have mentioned. What is important from you guys? You need to know the factors which are differentiating from the primary to secondary. Primary, it is only in young and usually with bilateral, and the secondary causes. Specifically, you cannot forget about the drug names. Okay, OCP, Argots, both having questions, even beta blocker also. Okay, so Argot derivative, this argotamine is causing more Raynaud's than pizotifane, because one question you have, both options are there, argotamine and pizotifane. So you have to go for argotamine. Okay, so this is important. These are questions. Okay, so we finish our Raynaud's. So Raynaud's associated, okay, no, not finish, management. Management, the first thing you will refer if you are thinking that this can be secondary. So first thing is refer if any secondary cause is there. Done. If medical management they want. Your first line treatment is nifedipine. Your first line treatment is nifedipine. Okay. Just remember this. Our past medicine, forget about this CCB and everything. What I am telling, just quote it. Okay. Other things cut. Management portion of Maghrabi is backdated. Again and again, I'm telling you. Any guidelines, don't read from Maghrabi. Whatever I am telling, whatever I'm writing, make it a note, or if you are not that much comfortable, go to our past medicine PDF, what I have shared with you, go there. from there also you can get the same management I'm telling you now. Okay, dear? So these are backdated. So first line is our nifedipine. Second line, IV prostacyclin, epoprostenol. That's it. First line is nifedipine. Second line is IV prostacyclin, or you can get it as a epoprostenol also, because I got one of your question, epoprostenol. So this is like a prostacyclin, okay, derivative. So that one also you can get. That's it about your management. Don't go with so many details over here. Whatever I have told you regarding management, enough for you guys. Okay. Now come with our, I told you, so see, secondary causes, one of the causes is what? Systemic sclerosis or scleroderma, right? So now we will read about the systemic sclerosis. Now come with our systemic sclerosis, okay? Systemic sclerosis, there are 3 types of systemic sclerosis, okay? One is limited, one is diffuse, another one is the morphia, okay? Limited means what? Limited means, just let me draw a very funny cartoon for you, because if I'm drawing now with my cursor a human body, it will be obviously like a cartoon. So just let me give you some entertainment. I'm sorry, because okay. See how funny I can draw? So you will not forget. If I'm not doing it a funny way, you will not remember, right? So don't think I cannot draw. Okay, so let me tell you. Okay, so this is about our limited one. First, limited, which areas, if involved, which you are thinking of limited, okay? Usually limited if you are touching, not touching, yes, if you are touching your face or head with your hand up to the elbow, and if esophagus and lungs, this is your limited. This is your limited. I told you here only esophagus and lungs, okay? Now, diffuse, what it should be? If it is like chest, abdomen, here this part up to the elbow, okay? If it is involved, down also, no problem. So if it is involved, this is like diffuse. I mean, other than the portion of the limited, if it is diffusely, the word diffuse means what? Diffusely scattered, right? So if it is diffused rather than this limited, this is the diffuse. So you see, there is some area it is overlapping. What is that area? Lungs. Lungs is the thing, it will be overlapped between the limited and diffuse. Usually, in case of limited, you will get pulmonary hypertension. In case of limited, you will get PAH, whereas in case of diffuse, you will get interstitial lung disease. So both of cases, it will involve the lungs, but in a different way, in a different way. Is it clear, dear? So this is our difference between the limited and our diffuse. And the third one is morphia, that is just a skin manifestation. Okay, so that is like a plaque or linear-like fibrosis of the skin. Okay, I mean, there's like a plaque-like lesion will be there. So that is different, just skin. So that is usually, it is easy, very easy to diagnose. But where people get confused between the limited and the diffuse one. Limited and the diffuse one. And I think I already have shared you the things that it can be positive with limited and that diffuse one. I will explain that one also. Okay, so just let me read our Magrabiser's book. So Raynaud's can be the first sign they told in case of limited. So in case of limited, the word you will remember is crest. Just a minute, I need to skip this. Okay. So crest syndrome. Oh my goodness, why it is not clearing? Okay. So limited is associated usually with crest syndrome. What is crest syndrome? If this is a abbreviation, if you elaborate this, what is that crest? C for calcinosis, R for Raynaud's. That Raynaud's, just now we have read it in our previous page. Okay. E for esophageal dysmotility. Did I show you the cartoon with esophagus? I showed you, right? So this is esophageal dysmotility. Sclerodactyly, sclerodactyly in the finger of your hand or legs. So this is the finger, sclerodactyly. Okay, calcinosis also you will get it in a finger, telangiectasia. So this is the thing if you are getting, and this is known as your limited. So what can be the complication as it is associated with esophageal dysmotility? What happened actually here? Here is happening more fibrosis because of increased activity of the fibroblast. So everything getting tight, So if your esophagus getting tight, what it will happen? You cannot even swallow things inside. You cannot put your food down, right? So there will be malabsorption. The patient will come to you, I don't like to eat because it's very painful if I'm trying to swallow things. So they will have ultimately malabsorption syndrome because there is esophageal dysmotility is there. Okay, dear? Because of this sclerosed small intestine. Sometimes even it can have with intestinal obstruction also. So malabsorption, intestinal obstruction, you can get as a CREST syndrome complication. This is one of your important question. Another, I told you, lung involvement, which one here? Pulmonary hypertension. And the most common complication, if they are asking, this is also another question. What are the most common complication of systemic sclerosis? PAH, ILD. That means lung is the main most common complication in systemic sclerosis. And if you remember, I just want to recall things. RA, I told you, people are dying, most common complication, IST. Okay. Same when you will go to Paget's disease, you will go, people are dying of cardiac failure. So whenever you read, you need to interrelated the things here. So the complication why people are dying mostly, these are the things. Okay. No. Now come, this one is our complication, our CREST syndrome. So this is the limited and CREST. Now come, I told you that I have given you that specific, all the antibodies together. That one, I will open that specific image and I will describe that time. So this anticentromere, I will discuss later. Just let me finish all the features first. Okay, dear? So limited, we finished the feature. Now come with our diffuse one. I'm sorry, every time I have to clear my drawings to go to the another page. So, okay. So diffuse, what? Trunk and proximal limb. Is my cartoon okay? Yes. Proximal limb means up to the elbow, the proximal part of the limbs. And trunk, I told you, the chest, the abdomen, this is involved. That's it. And usually lung fibrosis, ILD, renal, cause hypertension, these all associated with diffuse one. Okay. Morphia, this is a localized scleroderma. So this is dermatological without any internal organ involvement. So this is only skin manifestation, I told you. Got okay. So this one well-defined oval or round plaque, if they're asking, this is morphia. That's it. And systemic sclerosis, you can have elevated ESR, CRP, hypergammaglobulinemia. These are not that much important because the sign symptom is enough to choose your correct answer in systemic sclerosis. Okay, there will be tightening, there will be dysmotility, there will be malabsorption, or patient will come with the patient can come like skin tightening with malabsorption syndrome, or maybe skin tightening with dyspnea. The patient cannot breathe because lung involved, or Raynaud's phenomenon. Then patients have skin tightening, and then maybe the patient came with you hypertension. Then again, this is systemic sclerosis. So from sign symptom, you can easily go up to there. Another thing you need to remember, this anti-copper zinc dismutase antibody is positive in case of dysmorphia. So this one is one of your question. Okay. Now come, so much important thing, the major complication they want to ask that if renal crisis is there, it is very emergency. I mean, not emergency, you need to treat it. This is one of the major complication, but not the commonest. Commonest is lungs, just as I told you, PAH, ILD. This is a direct question, MRCP. What is the most common complication of systemic sclerosis? That is the most common, I told you, lungs. Most common, lungs. But this one complication, this is just a major complication because they love this complication treatment. That's why they have mentioned it here. So many complications are there, but this one, they love it because they are giving you question from there. Systemic sclerosis, how they will give you this question? They will give you, the patient is like systemic sclerosis patient, or maybe they will not mention some feature they will give you, like same skin tightening, Raynaud's phenomenon, and crest features are there. Along with that, you see, they will give you maybe hypertension is there. Hypertension, I mean, BP high, patient cannot see well, and the renal RFT dearranged, renal function test is dearranged. Even sometimes it could be associated with heart failure also. So the main theme is that if systemic sclerosis patient is in your question, BP high, treatment, oral SE inhibitor. Oral SE inhibitor. That is the very favorite question of MRCP. Okay, so this is scleroderma renal crisis. If a scleroderma patient you see in your question with hypertension, and obviously other feature also they will give. Sometimes even they are not fulfilling the all the features like retinopathy and heart failure, renal function test, not filling the, not fulfilling all. Just they will maybe give you like hypertension. Please go for oral SE inhibitor. Even if it is high, don't go for IV. Don't go for IV. You cannot use IV here. Even it is high, a very high malignant hypertension. Okay, you cannot put the BP down suddenly here. Okay, so that is why they love it. That they will give you like malignant hypertensive type range, and they will give you scleroderma patient, and they want you the treatment. And you will think, oh no, BP is so high, I have to go for IV maybe. No, you have to go for oral SE inhibitor. That is what they want from you. Okay. Okay, so just give me a moment. I want to go to that image. Otherwise, the antibodies will be, I will forget to tell you. Just I'm stopping sharing, so I will go to that image and share it again. Okay, just a minute. So, what is that I want in our E1 group I shared, right? Where are my features? System. Is it helping you, doctors, or not? Just in between.
Yes, it's helping a lot. Thank you.
Welcome, dear. Welcome. Thank you so much. Thank you so much. Yeah, I got it. Just let me download it and open. Okay, let me share. Here is Zoom. You can see it, right? The image?
Yes, it's clear.
Yeah, thank you. Thank you. Thank you so much, Dr. Dikash, Dr. Ivathi, Dr. Mama. Thank you. Okay, so this one, how you will remember. I told you guys to memorize this. If you are finding difficulty, just I will tell you my way. So if you have already memorized it, just skip this point. Okay, so how am I remembering this? When it is limited, it is in the center. It is not a theoretical thing there. It is just the mnemonic how I am remembering. Okay, so if it is limited, that means I'm thinking this may be in the center. So that's why anti-centromere antibody is positive in limited. Okay, and also I told you in a limited pulmonary hypertension is there. So how I am remembering this, let me tell you just one clue. You know, I am in Oman. I don't know if you guys know me. Right now, I am in Oman, working as an emergency doctor over here. So here, you know, deaths or palm trees are more, okay? So I will tell you just one line that somebody has got 3 palm trees in the center of his garden, okay? 3 palm trees in the center of his garden. Why I'm telling you? Come here now. Anti-U3RNP. This U3 means there is 3. Palm tree means pulmonary hypertension, PULM, that pump, okay? So palm tree, so pulmonary hypertension is associated anti-U3RNP. This pulmonary hypertension also can be associated with our centromere antibody. That means that is the limited one. So 3 palm tree is the center of the garden. Limitedly, if somebody has if somebody is planting, that is our clue to remember the anti-centromere antibody and anti-U3RNP. These 2 finish, okay? Now, just a minute. Let me draw and yeah. Now come when it is diffuse. When it is diffuse, let me change color. Okay, anyway. So when it is, just a minute here, just a minute. Yeah. So when it is diffuse, so diffuse, I told you already that, so if you already know that pulmonary hypertension is associated with the center one, the other one is associated with the diffuse one. So it's finished. So diffuse and ILD, it is associated with our anti-SCL70 or anti-topoisomerase 1. Anti-topoisomerase 1. Okay. So anti-centromere finish, anti-SCL finish, anti-U3RNP finish. Anti-U1RNP, this one is the mixed one. This one is the mixed one. Anti-PM-SCL, PM means what? Polymyositis. So this is associated with myositis. That's it, finish. So when SS associated, SCL means sclero. So this SCL is indicating to SS and PM means the myositis. That's it, very easy. From the antibody name, you will understand. Now come the last one is anti-RNA polymerase 3. Anti-RNA polymerase 3, this is with renal crisis or cardiac. Cardiac means same, no? Renal crisis, I told you. What is the renal? Just now I told you that that scleroderma renal crisis containing retina, containing your RFTDRNs, containing cardiac failure also. So this renal crisis associated with your this RANA, this RNA. Okay, so this that I was remembering this like that polycystic kidney also. So kidney, that's how I was remembering that cardiac and renal both with RANA. So like that you can remember this one. Okay, so that's it. Center, if 3 palm is there, it is your centromere antibody. If it is diffuse, the other one of the lungs, that means ILD. So diffuse and ILD with your SCL70. The others are with your antibody name. That's easier. Okay, that's it. So let me share, go back to our main book. Where is my book? Just a minute. Just a minute here. I'll stop sharing maybe. Can you see Maghrabi? Is it there?
Yeah.
Okay, thank you, dear. Okay, so now we have finished with our systemic sclerosis. Now we will come with our next topic, dermatomyositis. Dermatomyositis. First, dissect the word, right? As I told you, always dissect the word, then you will get it. Dermato means there will be skin. Myositis means there will be muscle inflammation, itis, right? So there will be weakness. So dermatomyositis means there will be some dermatological infestation, and myositis means there will be some muscle infestation also. Okay. So dermatological infestation, what you will get? You will get that patient is having some signs, some rashes. So what are the rashes? Around the eyes and cheeks, you will get one kind of rash that is known as heliotrope rash. Okay. There is a rash over the back and shoulder that is known as shawl sign. This all signs pictorial image very important for part 2, but for you guys, no need. So I will not overburden you to see all the pictures, but yes, somebody if interested, you can go to Google and can search and you will see all the signs over there. Okay. So just remember, if the rash around the eyes, this is heliotrope rash. If the rash is like a shawl, you know shawl, what is shawl? A shawl means what we are wearing over our shoulder during the winter. Okay, so that's covering the back, the upper back and our shoulder. So in that area, if there is any rash or redness, so that one is known as shawl sign. So we feel there could be shawl sign, there could be heliotrope rash, or there could be some Gottron's papule. What is the Gottron's papule? You will find the knuckles of the finger. What is the knuckles? Okay, just a minute. Just I will have a quick. Okay, just we will have a quick look because I'm not feeling satisfied. Okay. This is the heliotrope rash. Okay. If you can see, this is the heliotrope rash around the eyes. Okay, dear. Now come with our shawl sign. This is our shawl sign. You see, like the upper back and shoulder, upper back and shoulder. You can see my Google, right? Can you? What I'm sharing?
Yeah, visible.
Okay, thank you. Okay, this is the shawl sign. Now come with our Gottron's. These are the knuckles, the prominent part of our joints. Okay, so if it is getting red, this is the Gottron's papule. There is papule-like lesion, if you can see. Just see this picture. This is good one. This one. Okay, dear. So this is the Gottron's papule. Also, you can have telangiectasia also. So that's about our. Okay, we will go back to our preview. Okay, so that's it about our dermatological infestation of the dermatomyositis. Now come myositis means, so muscle, there will be what? There will be proximal muscle weakness. So cause this polymyositis, again and again, I'm telling you, this is a part of dermatomyositis, which one is not having any skin involvement. So if only muscle involvement, that is known as the polymyositis. Okay, so this is our polymyositis. I differentiate you from the PMR. From the PMR, I told you that it would be high. See, CK is high. And I told you there would be weakness. Proximal muscle weakness would be there, which was not present in PMR. Which was not present in PMR. Again, this polymyositis, how you will differentiate it with nervous system, with the neurological symptoms. The all sensation and reflex will be normal here. So there will be no upper motor or lower motor type of lesion. Got my point? So we have to differentiate all one by one. You have to know from PMR, just let me write, so it will be like a visible. So you need to know that we are actually differentiating from PMR, then we have to go for polymyositis. So PMR is like only there will be pain and stiffness. Polymyositis, there will be weakness. But when there is neurological upper motor, lower motor type of lesion, neurological involvement, there will be also the other signs symptoms of nervous system. I mean, there will be maybe fasciculation, sensory and motor activity will be affected. Which one is not affected in case of our polymyositis? So this is the thing Where it need to be very clear there. If anybody is not clear, please tell me, I will repeat it, but you cannot just skip this. It has to be very clear that what is PMR, what is polymyositis, and how we will differentiate from other neurological neurological diseases. Okay. So now come, as I told you, so dermatomyositis, it would be both dermatological infestation and also there will, okay, somebody has given any, thank you, clear, thank you, Dr. Daksh. Anyone else? Why it is not cleared? Okay, you want me to repeat? Okay, dear, I will repeat. I told you PMR. Let me write it here. PMR, it was only with what? It was pain plus stiffness only. There was no weakness. There was no weakness. Patient will be stiff, but if you see, I mean, the activities if you are doing, you will not get any weakness. Okay. In case of polymyositis, you will find the weakness, but you will not get any neurological sensory loss. No sensory, the loss of sensory, I mean, loss of sensory will not be there, or there will not be fasciculation. You got my point? So if involved, like sensory involvement or fasciculation, that is different. That is maybe the patient is having any neuron lesion, upper motor neuron lesion, lower motor neuron lesion, other neurological sign symptom. Okay. Okay, PMR full form polymyalgia rheumatica. Polymyalgia rheumatica. Okay, dear. So even from the name you can get it. Myalgia means pain. Rheumatica means associated with your articular joints. So joint stiffness and pain. That's it. Okay, dear. Okay. So now the treatment of polymyositis, again with high dose prednisolone. Now I think I have already mentioned the last day. I will again mention it. I will repeat it because this one, PMR and DIL, drug induced lupus, these two are with low dose prednisolone treatment. GCA, giant cell arteritis, and polymyositis. These two are high dose. Your treatment of these 4 diseases finish. That's it. This is the summary. Okay, dear? Okay. Now, okay, another thing is that if they're asking you that in dermatomyositis, which antibody is common? If they're asking most common, you need to go for ANA. There is a question in past paper of part 1. Okay, dear? So if they're asking most common, then you have to go for ANA, not anti-MI2, not anti-Jo1. If they are asking specifically what is specific for dermatomyositis, you have to go for anti-MI2. If they are asking what is specific for polymyositis, you have to go for anti-Jo1. So remembering this, how anti-MI2 and Z1, usually these two are mixed up sometimes. So just remember Jo-Po. Jo-Po. Jo is associated with Po. Jo is associated with Po. That's it. Okay, so other one, the MI2 is associated with dermatomyositis. I think it's clear. So ANA common, but if it is specific, so it is overall. ANA is overall for both dermato, for both dermato and polymyositis. Got my point? But if they're asking specific for derma, it is anti-MI2, and our for Po is Jo. That's it. Okay. There is a topic here, inclusion body myositis. Usually this polymyositis is happening in the less than 50 years of old, whereas this inclusion body myositis will have more than 50 years of old. This topic I will not discuss it here, because neurology I will discuss it. Otherwise, this has actually not that much correlation with that one. Only that there will be some muscle biopsy will get some change, but this is actually under neurology. I will discuss, inshallah. Okay, dear. So I'm skipping this one. Okay, there is one thing, anti-synthetase syndrome. This is associated with Raynaud's, myositis, high CPK, and positive anti-ZO1. So that specific question was not having with our polymyositis. Okay, dear. So that was with option was anti-synthetase syndrome. So it will be easier for you. You cannot be confused, inshallah. Okay. So this one, just have a look. This is one of your question. Okay. Now, anti-RNP, mixed connective tissue. Just now we have learned, right? This one is U1, not 3-pump, not 3-pound tree. This is the anti-U1 RNP. Anti-U1 RNP. This is not RANA. RANA is our cardiac and renal crisis. Okay, that's it. Okay, so now come with our osteoarthritis. Do you guys need break, coffee break, or I will finish osteo after that? We'll take a break. No one needs break? Okay. Break. Okay. So we will have a coffee break or tea break, whatever you want. So we'll have only 10 minutes, inshallah. Then I will be back. Okay. Thank you, everyone. Have a coffee.
Approximately till what time will the class continue?
Actually, today I was expecting it would be maybe more than 3 hours, dear. So I don't know how many remaining. Let me see. Budgets, osteopetrosis. Just let me check. Yeah, it will take at least 1.5 hours. Yes, dear.
Yeah. I'm saying that do you have your own any personal groups or something like that? Because I attended your session. I'm attending your session for the first time. So if you can add me to your group, so that would be great.
Yeah, doctor. I have my group. I have a course. So everything is there. So which group you are in? Just let me stop my, wait, just a minute. Let's stop my recording.